State for Health, Social Care, and particular pleasure after you came here to launch the changes in PHE a few months ago. Always good to have you on our platform. Just perhaps the big opening question here at this virtual Fringe Meeting, virtual Conservative conference. The thing which I think is in lots of people's minds is so much of your focus has been on prevention, technology, and now 40 hospitals. The big question, why?
Well, that's...
How do you square the circle?
How do we square the circle between the need to build more hospitals and also the focus on preventing ill health and on technology? Well, I suppose the answer is this, that for the NHS to be sustainable over the long term and for us to protect it over the long term, it needs to do far more to prevent ill health and also needs to use technology better, which will save costs and give clinicians back time and is better for patients. And I'm a massive enthusiast for that agenda. But we also need to ensure that when you do come into hospital, you get the top quality, cutting edge treatment. And I suppose it's I think of it as a hub and spoke, as you know, you need those high quality centres that are centres of scientific learning, that are centres of care and treatment, that are able to bring together people and of course treat people. And at the same time, we need to make sure that more people can be treated at home. We can do more diagnostics in the local community. We can break down the barrier between primary care and secondary care so that the GP isn't artificially separated from the rest of the system in a way that has been the case for over 100 years now. But you've got to have the physical hubs of the highest quality, and I'm really thrilled that we've been able to announce 40 new hospitals, and they'll be built over the rest of this decade. And we've got a competition for 8 further that we're going to build before 2030, essentially putting in place a long-term pipeline. You know, there are some that are currently being built and they need to obviously be completed. There's a whole load that need to be built in the next, essentially immediately. And then we've got a pipeline over 10 years to really replenish some of the older NHS stock, where in places like Watford and Harlow, where they have a Reading, wonderful hospital in Reading, absolutely beautiful facade, 19th century facade, but behind it, people still being treated in Nissen huts from the war.
If I just ask, please, because I know there'll be people wanting to be asking questions, please, if you could stick up your virtual hand so we can have as wide a range of questions for Secretary of State as possible. The announcement on Friday, just following up now on what you're talking about, there was talk about the guidance helping to standardise design for the new hospitals for the purpose of accelerating construction. You've been a long time supporter of building beautiful hospitals, not least because of the impact on mental health, recuperation, and the sort of connections between all of that the built environment and the green environment, around hospitals and so on. Just like you to reflect a little more on that, because it's been a subject, obviously, of great interest to policy exchange in the housing sphere, but perhaps it's newer for people in the public construction hospital sphere.
I think I would love to see a big public debate about what a future hospital should look like, both in terms of ensuring that we get the treatment that we can out into the community, whilst doing the more complicated treatment that's necessary in the hospital itself. Making sure, of course, that the technology is built into that. But making sure that hospitals are beautiful places where care is built into the architecture. And there's a growing medical literature about the impact of aesthetics on well-being and on recovery. And so this matters from a health point of view, but it also matters from a civic point of view. Often the hospital is one of the most important public buildings in a town or in a city, and we should make sure that they add to the community in which they are embedded. Now, there's another interesting aspect, which is precisely where you put the hospitals, because you want to make them as accessible as possible in the way people live their lives now, which isn't always in the centre of town, is in some cases. That'll depend very much on looking at the local geography and working with the local leaders and the local authorities and councils. But there's I think a big debate about what we want our future hospitals to be would be really important right now that we've made this commitment, delivering on the manifesto with a long pipeline, some, as I say, which we are ready to get going on immediately, but others that do require that work to get them up to speed. There's another aspect to this as well, which is to ensure that we get the very best value for money, where a modular build approach, so that you can build them in a way that they can be expanded relatively easily in future, is appropriate and important too.
And in terms of just going back to what you're talking about the 8 new hospitals, just a little more about the nature of the competition for those, just sort of more flesh on the bones.
Yeah, so we'll open a competition for 8 more hospital projects, including mental health hospital projects. And that's because whilst we've been able to announce the 40 that the Prime Minister set out on Friday, there's clearly more that needs to be done. And we've got a pipeline of this development to keep working through. And instead of the hospital building projects being sort of individual projects seen separately from each other, we're turning it into a health infrastructure plan that is a long-term plan to renew the physical facilities, alongside, of course, the need to change the way that the health service operates to be more of a preventative service, more embedded in communities.
And in terms of, you talked about some of the facades earlier, the much loved, and the sort of building beautiful, and then you said, behind that, the best possible technology. A little bit more maybe in this context now, here on this platform, on the kind of technological improvements, how the aesthetic would
well, in a way,
match up with the modern, the best of...
so inside your hospital, you need to ensure that you have obviously the best possible kit. That's fairly straightforward. But critically, that a hospital is part of a local health system. It doesn't stand apart from it. A hospital isn't an island that is separate from your community, from your primary care, from the other parts of both the health system and the work that is delivered by the local authority, for instance, in public health. So there's a need right across the board to ensure that your hospital is embedded in the community and part of the community and doesn't have the sort of silos around it. Where the rubber hits the road on this is on data, making sure that information is appropriately interoperable between the different agencies who need to see it, so that instead of having to go around and every person you see you have to describe exactly what's happened in full from the start, people can be treated according to where they're up to and much more focused on the individual rather than each individual every time they have an appointment being treated as if it's the first.
And a little more on the detail of, say, you've got a great hospital here, with a new hospital with a great design, with all the appropriate and the most modern technology there, about the sort of outposts, as it were, of that great hospital. Just say a bit more about how that might work.
For instance, I want to see diagnostics much closer to the community. There's enormous interest in testing because of coronavirus, and I understand that Of course I do, and I'm a massive enthusiast for it. But let's reflect on that question. People are incredibly enthusiastic if they have symptoms of coronavirus to know if they've got it or not. And they yearn for that test and then for the test result. This should be a principle that we apply more broadly, that if you've got a problem, a health problem, then we should do much more testing to find out what it is, even for low-level problems, like if you've got symptoms of the flu. The solution to this is to get diagnostics out of hospitals into the community where they're planned diagnostics. It's closer to home, so it's better for the patient, but also separate from the hospital, so it's safer from infection control point of view. And then you need a separate set of diagnostics in the hospital for use in the emergency room and by when they're needed urgently. Because at the moment, you often, in most hospitals, you have one set of diagnostics, one set of CT scanners, MRI, for instance, and you can have people with a time slot to go and do that, and then a case comes in through A&E, or somebody who's having an operation takes a turn for the worse, and they urgently need a scan, and it can knock out the timescales. But these are two different tasks, really. One is the emergency and urgent need for diagnostics. The other is the planned need for diagnostics in the community, where that can be done. It doesn't need to be done in the hospital itself. So the hub and spoke solution is an important part of what we want to pull off.
And on a slightly different tack, final question from me, and then we'll open to the floor, and a number of people want to come in. Now, PFI building wasn't a great success.
No.
In a number of ways last time, to say the least. Just was interested in your reflection how we would avoid that.
Well, we're going to do this hospital building programme on the government's balance sheet. That's incredibly important for having flexibility in how it's delivered. We've got to drive the savings, and we've got to make sure there's good value for money, we've got to do it in a way that allows things to change in the future. My big criticism, there's lots of criticisms you can make about the use of PFI. The fact that it was used to try to keep the spending off balance sheet, the fact that it often led to very high finance charges when currently the government can borrow at very, very cheap rates in the market. The biggest criticism from a health point of view is the inflexibility. Once you've built a PFI hospital, that's the hospital you've got. Instead, we should be building in such a way that as new innovations come up, they can be the building itself can be updated and evolved.
Thank you. So opening now to the floor, usual policy exchange, house rules, no question too outrageous. You just have to state your name and organisation first. I see first question from Craig. If you just state your full name and organisation, please. I'm...
You're reading them out.
I'm told, yes, that I'm good. On the Nightingales,
yes.
How do you want to repurpose them?
Yes.
After the pandemic.
So, Craig, the answer is that the Nightingales are there currently mothballed but ready for action should they be needed in this second peak, and I very much hope that they won't, but they're there for those purposes. But we do want to repurpose them as much as is possible. The Nightingale in Exeter, for example, where you're from, is able to be used as one of these diagnostic hubs, just as we were talking about. I'm really proud of the Nightingales project. People said that we'd never be able to build hospitals at that pace, and we did when we really needed to. And the NHS did it brilliantly. They did it in partnership with all sorts of other people. And so they're there as their first job, which is critical, is that they're there in case of a second wave. But absolutely we'll be able to repurpose at least some of them.
Thank you. And Deborah, asking about investment in general practice.
Yes, well, the thing about this, the drive for prevention is that we need more and more to be done in general practice, and general practice then needs our support to deliver it. We have a 5-year agreement with the GPs, but there's much more we could do to make sure that is that we have the best deal for both the GPs and also for the NHS and the taxpayer. And at the core of this has been the massive shift towards telemedicine, which I get very positive feedback from most GPs and also from patients. Of course, face-to-face appointments have always got to be there, but if you think about it, trying to ensure that people get care as close to home as possible means in the first place trying to ensure that that care can be given when they're in their own home, where that's possible. The next step is for the people to be able to travel a short distance to their local community healthcare, you know, whether that's a diagnostics hub we were just talking about or a GP practice, or often those two things will be the same thing. And then only travelling to the hospital if that's absolutely necessary.
And question from Shankar, it'll be one that I know will be dear to the heart of many people here. Improvement in hospital food. What's the future direction of travel and at so many levels of importance, and to staff as well?
It's so important.
Yeah.
It's so important, and I'm very excited about this. We asked Prue Leith to come in and review hospital food, and she's done a brilliant job. I've been on a few visits with her. She's you know, the question is, how do you, within the practical constraints of a hospital, and there are practical constraints, how do you make sure that people get food that is uplifting and improves their well-being, and especially because being in hospital when you're recovering from something, you know, it's not a particularly pleasant time. It can be very boring as well. Sometimes your meals are the thing you look forward to most. And so we should make them as good as possible. And there's hospitals around the country that have moved food preparation onto the ward, or they've or at least into the hospital itself, and you get a far better quality. I mean, I have with Prue, I have eaten some really delicious food in some of the best hospitals that do this well. They do it within the financial constraints that all hospitals operate in, and turning that from a rare exception. You know, Chichester Hospital has absolutely fantastic food. Well, that's great in Chichester. We've got to make that mainstream. So I want the thought that hospital food isn't good food to be one that's banished from the rest of the 21st century. And I have Prue Leith as my main protagonist in making it happen.
And a little bit more on preliminary thoughts on how that will be, that, say, you cited Chichester, how that message might be spread.
Well, I don't want to steal Prue's thunder, but her report will be published very soon, and I've seen a draft of it, and I'm very excited about this agenda. And I know how much it means to people. You know, I know how, if you ask people how their stay in hospital was, of course the care is an important factor in that, but the food is too. And it's so important. And, you know, the amount of effort that goes into delivering food in hospitals, we can absolutely improve this part of the NHS life as well.
A question from Fiona, and sort of half mixed with my own, is that you were as we've said, long-time supporter of better design, the sort of the appearance of hospitals, and as you said, there's the growing weight of medical evidence on that.
Yeah.
That predated the pandemic, but what new information from your point of view on the design of hospitals comes out of the pandemic? What's changed between then and now?
Well, I think that there was a push in the NHS pre-pandemic towards having parts of the NHS that are essentially planned and elective, and parts that are essentially acute and responsive. And this push has been massively accelerated by the pandemic because of the need for infection prevention and control. So if you have a health concern, you need to go in for an operation, and you know it's going to be in the next month, but if it was in the next 6 weeks, that would be fine as well. So we're talking about non-urgent care. What you want is a date relatively soon when you know you can go and you're not, and it's not going to be cancelled at the last minute. When you have a hospital that covers both acute and emergency response and that elective work, and the same people and theatres and diagnostics equipment do the same, then you get the knock-on from one to the other. Actually, one of the things that's been really reinforced is that you want to keep the elective work going as much as possible. And if you think about the direct pandemic response in the peak, a lot of elective work, unfortunately, had to be cancelled. But the second time round, we want to keep that going in what we call COVID green areas, i.e. areas where we have a high degree of confidence that there's no COVID. Patients have to quarantine before they go in. We use testing aggressively to ensure that there is no COVID in those areas. And then there's COVID blue areas where there may be COVID, say the A&E, where people just come in off the street, although we want to make sure that people increasingly call 111 first, but nevertheless, you can't be certain that somebody hasn't got COVID. And of course, the areas where they treat COVID. Now, having COVID green and COVID blue areas is necessary for the pandemic, but there's also a longer term issue, which is you want to make sure that your elective work and your acute work is separable wherever that's possible, so that you can get on with delivering the elective work in a planned, organised and systematised way, and not have to suddenly make changes at the last minute because there's a couple of 2 or 3 ambulances that have come in at once, and there's a huge amount of focus then on the emergency room.
I have a question from Pete, an NHS doctor, just a little more detail. It's a long time subject of great concern to so many people, just on travel to and from hospitals for staff. A little more on it.
Well, I think, look, we made parking free during the pandemic, not least because there's been fewer outpatients, and so there's more space in the car parks. And that has gone down very well with staff. I think this is part of this broader debate we need about hospital design, because it isn't inevitable that the right place to put a hospital is in a town centre. It may be, but it may be better where close to transport networks, for instance. We need to step back and from first principles think, since we're going into the biggest hospital building programme in a generation, all of these questions, like transport, like the aesthetics, and like the digital platform, all need to be thought of, worked through now, and then we can bring all these insights to bear on what is a very exciting long-term project, so that we get we learn what is the best design for a hospital, and then that's what we deliver.
Brilliant. Thank you. And a question from Steve Race. He's asking about clinical home care services, offering a solution to hospital capacity. How can the NHS work with that clinical home care partners?
I'm an emphatic supporter of this, and I suppose this comes back to your very original question, Dean, which was about, since I'm such a fan of preventative healthcare and care as close to home as possible, why am I also such a fan of building hospitals? And the answer is that you need both. You need to have. I put it this way, and really to tell the story. Over a generation, increasingly, care was concentrated in bigger and bigger hospitals, and that is right up to a point. Because if you're having a complicated procedure, you want to go to the place where the very, very best capability is, where you have the best people who perform that operation over and over again, have huge experience, where they also do research, so they're on the top of the cutting edge techniques that are available. However, if your treatment is more appropriate at home, you don't want to have to go to hospital for that. So a combination of pushing care where that's possible, as close to home and into the home where that's possible, and then having the high quality, high end scientific hubs in the hospitals for the treatment that must be done in hospital, this is the future of the NHS. It is slightly more complicated to explain than let's pull everything into one great big individual centre. It is pushing out where it can be, and it is bringing the hospital right into the 21st century in terms of the cutting-edge procedures that it does.
And final question, just a little more detail on how the new hospitals can sort of proof us against future pandemics. Just a little more.
Well, they'll be there. They'll be there to support people afterwards, and as we were talking about, it's important that that ways of combating infection are also built into the design of a hospital, as they are into any good hospital. That's always been the case, right from Florence Nightingale, and it's highlighted even more in the middle of a pandemic.
So thank you, Matt. Thank you again for giving your time today. Thank you for really saying a lot more about the subject, clarifying this hugely important area. We've run a call for evidence, as you know, on what the 40 hospitals should look like, 48 now, perhaps to add it. And so we urge, please respond to our call for evidence. It's still open. We'll be doing a lot more work in this space. Beyond that, watch this space. Look forward to you being part of that and that continuing dialogue with Policy Exchange's excellent health and social care team headed by Robert Eade and Richard Sloggett. And please, as I say, call in, please come in with your calls for evidence. And last word.
Well, thank you, Dean. And this, I think this public debate about what we want from our hospitals over the next decade and how we build the best possible hospitals within this project that we are, as a nation, have chosen to undertake. I think it's such an important debate, and I think that Policy Exchange's voice in that debate is clear and loud, and going to play a very big part over the months and years to come.
Good. Thank you. Thank you all. We look forward to welcoming you all back here for continuing discussion. Thank you.